So hello and welcome everybody. Today we have the second part of treatment of bronchial asthma, and actually we have today the stepwise treatment of bronchial asthma. So get a pen and paper near you and let's start directly with the step one. Step one actually is applied for all asthma patients, and it includes the administration of SABA or short-acting beta-2 agonist. So why do we use SABA for all patients with asthma? Actually, because it gives relief of acute symptoms. So we can give directly SABA for all asthma patients, but actually we should make sure that the increasing use of a reliever or SABA more than 3 times a week or triggering of symptoms from exercise provide an indication that control of therapy is needed. So we use SABA only 3 times a week as maximum. If there is a need to use SABA for more than 3 times a week, it means actually we need to use a control therapy. As we will know in the following slides, what control therapy we use for asthma patients. Actually, the most important SABA medications include salbutamol, albuterol, and terbutaline, and they are all given by inhalation. So make sure to give SABA by inhalation route. So next step, if the patient's symptoms are no longer intermittent. So actually, if we use SABA 3 times a week, the patient's symptoms should be intermittent. But if the patient's symptoms are no longer intermittent, we should add a long-term controller. So here we will know the control therapy in the second and third step. And actually the control therapy are given in a scheduled basis as recommended. The control therapy includes the addition of ICS or inhaled corticosteroids. And in the second and third step, we should start the inhaled corticosteroids with a low to intermittent dose and only twice daily. And we will wait till 3 months go. If the symptoms are controlled after 3 months, the dose should be stepped down. The most important inhaled corticosteroid medications include beclomethasone dipropionate. The dose is 200 microgram twice daily. But after 3 months, if the symptoms persist and aren't controlled, we go further to the third step, which includes the addition of LABA or short-acting beta-2 agonist. So the equation of the treatment becomes SABA plus ICS plus LABA, and they all are given by inhalation. And make sure to adjust the dose of ICS. So the dose of ICS should be adjusted up or down accordingly to the need for rescue inhaler treatment and to the control of patient symptoms. So in the first step, we give only SABA, but maximally 3 times per week. If 3 times a week of SABA isn't enough, we should go to the next step. We should add control therapy, which is ICS or inhaled corticosteroids. And then we should wait for 3 months. If the symptoms are intermittent, we should decrease the dose of ICS. But if the symptoms persist and aren't controlled, we go further to the next step, which is the addition of LABA. And also make sure that the dose of ICS is adjusted up or down accordingly to the need for rescue inhaler treatment and to the control of the patient's symptoms. In step 3, there is an alternative therapy, which includes the administration of low doses of oral theophylline, an anticholinergic, or an anti-leukotriene, but these are less effective than LABA plus ICS combinations. So in next step, and this step, the fourth step, is for patients with worsening symptoms. The treatment equation becomes SABA plus low-dose theophylline orally. So don't forget that theophylline is administered orally, plus high dose of LABA ICS. So in the previous steps, first, second, third, we use only low to intermediate dose of ICS LABA. But in the fourth step, we use high dose of LABA ICS. And in patients with severe asthma exacerbations who fail to achieve symptoms control, we use oral corticosteroids. The most important oral corticosteroid is prednisolone. The dose is 40 to 50 milligram. So in step 4, we use SABA plus low dose of theophylline orally plus high dose of LABA ICS. And if this treatment failed to relieve the patient exacerbation, we use oral corticosteroids such as prednisolone orally. Occasional anti-IgE therapy with omalizumab may be tried in patients who are CS dependent. You can guess what is CS actually? It is corticosteroids. And continue to remain in control, but this treatment is only suitable for highly selected patients. So why? Because, as I mentioned in my previous video, anti-IgE therapy is very expensive, and not all patients require this therapy. So next, allergen-specific immunotherapy may be considered in this group. However, the risk of severe events, including death, is higher in patients with severe asthma. So here guys, we finish our tutorial for today. Thanks for watching. Don't forget to like and share this video and subscribe to my channel. In my next video will be the management of severe acute asthma attack.